Welcome to the Arctic Gyne Center webinar series.
So I'll be speaking about dangers of pregnancy, about the maternal mortality picture in Nigeria. Then I will then speak about the danger signs of pregnancy and the other births preparedness and emergency readiness components. Then we will conclude. Okay, so speaking maternal mortality, meaning maternal death, means that it means the death of a woman while pregnant or within 42 days of termination of that pregnancy, irrespective of the duration of the pregnancy, irrespective of the site of the pregnancy, from any cause related to that pregnancy or aggravated by the pregnancy or its management, but not from accidental or incidental causes. So what that means is that when a woman is pregnant and for any reason she dies during that pregnancy from things that are related to the complication of that pregnancy, irrespective of how many weeks that pregnancy was, or where that pregnancy is in case of ectopic, for instance, or whether it was in the correct place, or if it's situations like diabetes or hypertension that was aggravated by the pregnancy, or sometimes it's even the management of the pregnancy, management of conditions in the pregnancy. And this is, so sometimes it could be iatrogenic, meaning that it could be caused by the healthcare providers, sometimes the way they manage the pregnancy, but not accidental causes. So if, for instance, somebody was attacked by an armed robber and shot, for instance, we don't regard that as a maternal death. Or somebody had a road traffic accident, it's not regarded as a maternal death. Or somebody dies of COVID, for instance, or one serious medical illness that will have killed the person anyway, irrespective of whether the person is pregnant or not, it will not be regarded as a maternal death. But every other thing is regarded as a maternal death. What are the So we're talking about maternal death because before dangers of pregnancy, because the dangers in pregnancy are the things that then lead to maternal death if not identified and if not properly managed. And as it stands today, in the world we live in, Nigeria still ranks one of the highest, ranks among countries with the highest maternal deaths in the world. We measure the indices of maternal deaths by what we call maternal mortality ratio. And that for Nigeria is still about 993 per 100,000 live births. We measure mortality ratio in terms of live birth because it's live births that we can account for, and not all pregnancies. So not all pregnancies we don't know how many pregnancies people have per year, but to a relative extent, to some level of accuracy, we can determine the number of live birth in the country per year. So that is why that is measured with respect to live birth. So ours is about 993 per 100,000 live birth. And for you to appreciate that, um, for countries like the United States, for developed countries, their indices are usually below 10. So maybe for United States, for instance, United States, for instance, um, the index is about 10 per 100,000 live births. When you compare that to ours, that is about 900 and something per 100,000 live births, then you will appreciate what we are talking about. The value that we have up till now is that of 2023. No recent uh, statistics have come up since then. It has been difficult doing uh, research for so many reasons. Our vital registration system is a problem in the country. So we still quote values as far back as 3 years ago. And as at that time, the number of maternal deaths in the country was stated to be about 75,000 out of about 550,000 that happened in that year. In Lagos, the statistics was about 430,000. I mean, 430 per 100,000 live births. States like Ondo states have lower values, but 112 per 100,000 live births. Um, Certain countries like Finland, for instance, they have levels as low as one or two per 100,000 live births. So if you're looking at the best country, at countries with the best maternal mortality ratio records, then Finland, even Spain, are countries with the best records, even better than uh, United States of America, for instance. So closely related to maternal mortality is perinatal mortality indices. And for perinatal mortality, we compare to all births. We use all births. So, so including stillbirths and live births, we compare the number of stillbirths or early neonatal deaths per 1,000 stillbirths and live births. Nigeria, again, still have very high ratios. Perinatal mortality ratio in Nigeria is about 41 per 1,000 uh, births, per 1,000 total births this time around, per 1,000 total births. Now, this is still a far cry from the SDG goals, SDG targets. SDG targets for maternal mortality ratio, for instance, is 70 per 100,000 live births. Compare that to 993, where we are up till now. There are certain individual studies that are even stating that levels for 2025 is already higher than that level, about 1,000 plus. Perinatal mortality ratio target, SDG target is 12 per 1,000 total births. We are still at 41 per 1,000 total births. To bring it home a bit, these values interpret to a death per minute of a woman in pregnancy. You know, what it means is that, for instance, if I'm going to be speaking for about 1 hour today, the statistics means that about 60 women will have died at the end of 1 hour all over the world as a result of pregnancy and its complications. So these are very serious values. And because of that, because we live in a country where we still have very high maternal mortality ratio records, we then need to prepare ourselves. We then need to do things to ensure that nobody falls victim. It is possible to carry pregnancies successfully. It is happening in certain parts of the world. It is happening in certain parts of the country also, where, people tend to do what is right. People tend to do the proper thing. And one of the mechanisms in which we prevent maternal mortalities is antenatal care. Antenatal care. And lecturing in antenatal care, giving health talks like the one we are doing today, is one strategy of antenatal care, so that people are informed about things that can lead to complications, so that they can take proper measures to prevent them. Now, a lot of factors are responsible for these maternal mortalities, from the government's commitment to health generally, obvious from allocation of budgets to health. In the country, up to today, our allocation to health is still a far cry from what it should be. What was agreed by African countries, the African Union, was that 15% of the budgetary allocation should go to health. But up until today, less than 5% of our budgetary allocation is being allocated to health. And that explains why our health sector is still where it is up till now. So there's poor political commitment, there's poverty in the country. Country still ranks one of the poorest in the world, a third world country. A lot of people cannot afford good health care. Culture and religion also plays a very important role. There are some people, their cultural practices are part of what is harming them. Some people, their religious beliefs is part of what is causing problem. And But obstetrics now, direct obstetric cause of maternal mortality, the commonest reasons why people have complications and why people die during pregnancy, the commonest one, the number one cause, is actually bleeding. Bleeding, what we call hemorrhage, obstetric hemorrhage, either hemorrhage from during the antenatal period, or hemorrhage during childbirth, or even after childbirth. That's the number one cause all over the world, including Nigeria, for why people die during pregnancy. At some points in Lagos, it was hypertension in pregnancy, what we call toxemia of pregnancy. That's about a few years ago, that was the commonest reason, and it still ranks one of the commonest reasons why people die during pregnancy. Hypertension, hypertensive disorders of pregnancy, preeclampsia, eclampsia, and so on. Infection, sepsis is another common cause of maternal mortality. Obstructed labor, abortions, and anemia in pregnancy. These are one of the commonest reasons why people die in pregnancy. And if we're going to prevent deaths in pregnancy, we're going to be looking at ways to prevent these 5 major causes of maternal mortality. Now, having quality antenatal care has been shown to reduce 60% of these deaths just by having quality antenatal care. And how does that help? Because people that tend to then attend antenatal care frequently, it is very likely that they are knowledgeable about these causes, number one. Two, it is very likely that when issues start to arise during pregnancy, these things are easily picked. It is always better when things are picked early so that they can be properly managed before it becomes a problem. So what are those danger signs? The ones that we should be aware of, the ones that are the most important. There are so many things, but the commonest danger signs that we should be aware of. I'm going to discuss this trimester by trimester so that we are aware. Now, in the first trimester of pregnancy, any form of bleeding at all in the first trimester, or as a matter of fact, in any trimester of pregnancy, is a danger sign. Any form of bleeding, whether it is spotting or heavy bleeding, anytime you see blood at any time in pregnancy, it's a danger sign. You have to quickly present to the hospital so that it can be evaluated and we know what is causing that bleeding. But particularly in the first trimester, bleeding can be a sign of a miscarriage, a threatened miscarriage commonly in most cases. And for threatened miscarriage, usually there will be bleeding, there will be painless bleeding for threatened miscarriage. When that bleeding is associated with pain in the first trimester, it might be as a result of an inevitable miscarriage. So sometimes, so when there's pain and there's bleeding at the same time, it may be that there's an inevitable miscarriage. Sometimes there's little or nothing one can do when that happens. But when there is no pain, then there might be a little hope. But more importantly, spotting or even brownish discharge, a brownish discharge in the first trimester, sometimes without pain, may be a sign of something very dangerous, like an ectopic pregnancy. Now, ectopic pregnancy is one of the commonest causes of mortalities, maternal deaths in pregnancy. So when somebody is bleeding, a woman of reproductive age that has some form of bleeding and is pregnant, we want to quickly rule out an ectopic pregnancy. And one of the first things one does when a woman is pregnant is to locate the pregnancy. There are a few people that are not that did not plan pregnancy, and they miss their period. Seen a few cases in the last few weeks, one or two cases, miss their period, and they're planning to terminate the pregnancy. Some people go and use pills. They just walk into a pharmacy to buy some termination pills, abortion pills, without even finding out where that pregnancy is. In about 3% to 5% of cases in this environment, pregnancies are not inside the womb. Pregnancies are outside the womb. It could be an ectopic pregnancy. Hyperemesis, excessive vomiting in pregnancy. Now, vomiting once or twice a day in early pregnancy, well, many times we regard as normal, but when a woman that is pregnant cannot tolerate any food at all, cannot tolerate any meal, then it's a danger sign. I've seen a case where somebody that used to weigh about 80 kg got pregnant, started vomiting because of the culture of not registering early in some parts of, even in Lagos. So people still believe in this day and time that registration for antenatal care should be at about 5 months. So you see some people, they are pregnant, they will say it's not time to go to the hospital yet. The person is vomiting, cannot tolerate anything, keep losing weight. Somebody I saw some time ago lost about 10 kg of her pre-pregnancy weight. And by the time the person presented in the hospital, it was too late. The baby was gone. So excessive vomiting is a danger sign. There are things that can be done when a woman is vomiting in pregnancy. Some vomiting can be very, very persistent. For instance, I'm very, very persistent. You're vomiting, you cannot tolerate anything. She presents in the hospital. There are so many medications that can be administered to help to reduce vomiting in many cases and even stop vomiting completely in many cases. Okay. Dizziness in pregnancy, in early pregnancy, severe dizziness, fainting attack. In fact, any woman that is pregnant and faints for any reason or the other, we have to rule out an ectopic pregnancy first. How to rule out an ectopic pregnancy. It is possible that that woman might be bleeding internally. So there's some hidden bleeding. There's some internal bleeding that may occur in the first trimester. There's no revealed bleeding. Person is just bleeding internally, and before you know it, there's dizziness, and the person may faint. So if that happens to anybody in the first trimester, it should be properly evaluated to be sure what is going on in the pregnancy. Sometimes it could be benign. Sometimes it's just from exhaustion. A lot of times, for many pregnant women, if you stand for too long, for instance, you may fall. That's a common thing. If you stand for too long, even in normal pregnancy, uh, before you know it, you may find yourself on the ground. But a lot of times when that happens, it has to be properly evaluated. It may be that something is going wrong in the pregnancy. So those are the commonest things for the first trimester, bleeding especially. In the second trimester, two things majorly that we should be aware of. Second trimester, so above 13 weeks, the middle 13 weeks of pregnancy, uh, common symptoms and signs that you should look out for that are signs of danger. One, pelvic pressure. So people that start feeling some weight under their abdomen, you feel like as if something wants to fall out of the vagina, can be a sign of danger in pregnancy. Especially people that have had previous uterine instrumentation. Commonly in this environment, previous termination of pregnancy. In our setting, a lot of women have had termination of pregnancy by uterine instrumentation, whether it's a dilatation and curettage or it's a manual vacuum aspiration. If anybody has ever had that type of procedure before, that person is at risk of what we call cervical incompetence or cervical insufficiency. And a lot of times it presents with pressure in the lower abdomen in the mid-trimester at about maybe 20 weeks, for instance. Some people will just complain that they feel some weight under the abdomen. It may mean that the cervix has started to open. Many times, there are no symptoms at all. The person does not feel anything. And in many settings, people go to the restroom to ease themselves. They sit down on the toilet seats, and the next thing, the water breaks. And if that happens in the mid-trimester in this country, that is usually the end of the pregnancy. But some people are lucky that they might have some discharge. They just notice some excessive discharge, and they're aware that, oh, this thing looks abnormal. Some excessive discharge. Some people start feeling that weight, and they're lucky, they're fortunate enough to complain to somebody that is experienced enough to know that something is going on. So we've seen a few cases where people have come to complain that they're feeling some weight, and we do a speculum examination, and we realize that the cervix is already opening without any serious abdominal cramps or pain. In some situations, we have been able to rescue those pregnancies by procedures we call a rescue sacrilege, and they are still able to carry the pregnancy to term. So that's very important, especially for previous instrumentation. So it might not be a manual vacuum aspiration every time or a DLC. Sometimes it's even procedures that people do to try to get pregnant. So people, for instance, that have had difficulty getting pregnant and they had to do certain procedures, for instance, HSGs, for instance, where the cervix was cannulated for one reason or the other, might also be at risk. A few people have had cervical surgeries in the past, maybe a cervical polyp, and it has had to be removed, and the fibers of the cervix has been interrupted during those procedures. Some people have had what is called hysteroscopy in the past, and during the procedure, they've had some form of dilatation. They might be at risk of a cervical incompetence. Now, another very important one is an abnormal vaginal discharge with a fishy odor. With a fishy odor. That's another very notorious and very serious danger sign of pregnancy in the second trimester. An abnormal vaginal discharge with a fishy odor is usually due to what is known as bacterial vaginosis. Bacterial vaginosis. Now, in bacterial vaginosis, what happens is that certain normal bacterial flora in the vagina overgrows its normal size, overgrows in the vagina. So sometimes, or many times, it is not due to a sexually transmitted infection, you know. So a woman that have not had any sexual intercourse since she got pregnant can have bacterial vaginosis, for instance. You know, if you perceive an abnormal odor, from the vaginal discharge, it should be properly checked. What happens in those cases is that the overgrowth of bacteria in the vagina in those cases causes what we call cervical ripening, starts to make the cervix soft. The cervix is supposed to be firm, like the tip of the nose, before the third trimester, before late pregnancy, when the cervix starts to get soft. It's supposed to be very firm, supposed to be able to hold the pregnancy. But in settings of vaginitis, particularly bacterial vaginosis, the activities of the bacteria in the vagina, elucidate substances that start to make the cervix soft. And before you know it, the cervix is soft and starts to open on its own from the sheer weight of the pregnancy. So if there's any abnormal discharge, it has to be treated properly, especially those with a fishy odor. So bacterial vaginosis is one of the commonest reasons why people might have a miscarriage in the second trimester, 20 weeks, even 24 weeks sometimes. And that's very important. In the third trimester, what are the things that you must look out for? Third trimester, from 28 weeks and above, if you have these complaints, danger signs, and you have to get it checked out. Now, if you start having reduced fetal movement in the third trimester, you have to complain on time. We usually say, in most cases, more than 95% of the time of the case, no baby just dies inside their mother, just like that. A fetus that has an issue, that has a problem, just like an adult that is sick, we start being quiet. When an adult is sick, when an adult has malaria, most likely the person will not go out or will not go to work for that day. The person will stay indoors, because there's no energy. The same thing happens inside the pregnant woman. When something is wrong with the baby, for one reason or the other, the baby stops moving. And most of the time, the movement starts to reduce. So if you notice that fetal movement is getting reduced, you have to complain. It might be something very dangerous. Because by the time a baby is 28 weeks and above, if there's a problem, the baby can be delivered at that time, to save the baby. Even though the baby will be transferred to a neonatal intensive care unit, but the baby can survive, after 28 weeks of pregnancy. If there's reduced fetal movement, there are certain tests that can be done to check what is going on, and if it's a situation that cannot be remedied, then the baby can still be delivered at that time. Your baby must move at least 10 times in 12 hours. 10 times in 12 hours. There are a few of us that we've had reasons to give a fetal kick chart to monitor the baby after 28 weeks when they complained of reduced fetal movement. The other things that we do, like a biophysical profile or a Doppler scan, to check what is going on if someone complains of reduced fetal movement after 28 weeks, very important. Now, complaints of headache, I was discussing with some people, over the weekend, about headaches. A woman complains of headaches. You have headache in the third trimester. Yes, it's good to use paracetamol, to relieve the headache. But if you have headache in the third trimester and you are pregnant, it's wise to visit your clinic to get it checked out. Now, a headache is not benign sometimes. A headache, many times, is usually a sign. It's not even many times. Anytime you have an headache, it's always a sign that that something is going wrong somewhere. That's the meaning of headache. If you have a boil in the leg, for instance, your body will respond by headache. If you have catarrh, your body will respond by headache. So it's usually a sign that something is wrong. But particularly in pregnancy, severe headache may be a danger sign, may be a sign of something very serious, like an hypertensive disorder of pregnancy, preeclampsia, for instance. We've had situations where people have headaches and their blood pressure is normal, and yet they have the most severe form of preeclampsia called HELP syndrome, for instance. A lot of times when people have preeclampsia, yes, the blood pressure will be high. They will have protein in the urine. For instance, ordinary benign pregnancy-induced hypertension, it might just be an elevated blood pressure alone with normal urine, with normal urinalysis, But even sometimes, this was what we were discussing over the weekend at an health forum. But even sometimes, the blood pressure might be normal, and yet the person is having some form of hypertensive disorder of pregnancy, even with a normal blood pressure. Okay, a blurry vision, when you start looking as if one is seeing stars, blurry vision, upper abdominal pain, especially on the right side of the abdomen, upper abdominal pain, especially on the right side of the abdomen, epigastric pain, or swelling of the body especially non-dependent swelling of the body. Non-dependent swelling of the body. So for instance, it's in about 70 to 80% of women, their legs will swell up at some point or the other in pregnancy because of obstruction to blood flow in the abdomen. So the leg swells up. So usually would advise, put your leg on a soft pillow when you sleep, lie on your side, either right or left, and all that. But when people start having swelling in the hands, the hand is swollen, these are non-dependent part of the body, or the face is swollen, then it's a danger sign. It's a danger sign. This might mean that their albumin level is reducing drastically. They are losing a lot of protein in their urine. So by osmosis, protein is flowing out into the subcutaneous tissue, and the body is swelling up. This is usually one of the signs. This is usually one of the signs of preeclampsia. It's usually one of the signs of preeclampsia. So if you have that, you have to get it checked out. Now, preterm contractions, painful preterm contractions, or sometimes frequent preterm contractions that may not even be painful, but it's too frequent, are also danger signs. Yes, from about 30 weeks in most pregnancies, people will start to have what we call Braxton Hicks contraction, which is normal. Usually it's painless. You feel like the abdomen is hard, then it relaxes on its own, but it's usually irregular, it's usually painless. But when it gets painful and it's a bit frequent, every 30 minutes, for instance, then it's dangerous. It can lead to labor eventually and lead to delivery of a preterm infant, the preterm baby. Drainage of liquor, drainage of fluid for any reason, in the preterm stage before 36 weeks, it's also a danger sign. So sometimes people's water can break early in pregnancy without any pain, what we call pre-labor rupture of membranes or premature rupture of membranes. When that happens, even at term, so a common scenario is that some people, they're already 37 weeks, 38 weeks at term, and their water breaks. And some people are waiting for contractions to start, for labor to start before they come to the hospital. That is wrong. If water breaks at any time in pregnancy, whether it is preterm, whether it is term, it's always an emergency. So usually when I discuss signs of labor with people, I tell them, if your water breaks, even if you don't have any pain, please carry your bag and start running to the hospital immediately. It's always, it might be dangerous. It might be dangerous, Then bleeding. Again, bleeding is coming up here. I've mentioned it earlier. Bleeding anytime in pregnancy, it's a danger sign. So bleeding happening in the third trimester, the commonest reasons why bleeding might happen in the third trimester before labor is what we call placenta previa or placenta abruption. So in placenta previa means that the placenta is low in the uterus or in the womb, is low, and usually there will be bleeding. It might be mild, it might be a lot, and there's usually no pain. There's usually no pain associated with that type of bleeding. It's a very dangerous condition in pregnancy. The other type of common bleeding in the third trimester that is very dangerous is abruption of the placenta, what we call placenta abruption. That's abruption of the placenta. That's separation of the placenta. So sometimes the placenta can separate on its own, can detach from the wall of the uterus. And there are reasons why the placenta can detach from the uterus. Commonly in people with high blood pressure, the placenta can detach in situations where the placenta is not implanted properly, in early pregnancy, it can detach. People that have had previous uterine surgeries, people that have polyhydramnios, the placenta can detach. Trauma to the abdomen, a fall, for instance, can detach the placenta from the wall of the uterus. And that will usually come with bleeding and pain. Sometimes there's no bleeding at all. Sometimes it is concealed bleeding. So in 20% of the case in 20% of the time of placenta abruption, there's no bleeding outwards. It might just be pain. So if someone has pain also in the third trimester, you're having abdominal pain, you should get it checked out. Something might be going on. It might be due to separation of the placenta. Sometimes it is a fibroid degeneration. So another very common one that we're getting to see a lot of times, is fibroid degeneration. So many women, uh, it is said that up to 60 to 70% of women have some form of fibroid or the other, and it might not be symptomatic before pregnancy. In pregnancy, it can cause a lot of problems, including pain, and we've seen cases whereby people have pain, what is called fibroid degeneration in pregnancy, and that has led to uh, contractions, preterm contractions, and have led to early delivery of a premature baby sometimes. Okay, so that's another one. Now, we've added signs even after delivery, danger signs even after delivery, and headache again ranks number one. Headaches again rank number one. I've seen about uh, two, three cases when I was practicing in a general hospital that, these women just came, they presented with headache. In one case, somebody presented with headaches of about 3 days duration. And by the time she decided to come to the hospital, it was when the headache was so severe that, she was feeling pain at the back of the neck that she decided to present. And she presented to the hospital. And on presentation to the emergency room, she started convulsing, and that case was very dramatic because she started convulsing, and from there on, there was no turning back. So from headaches to convulsion, and that was the end. You know, so headaches are something that must be taken very serious, especially after delivery. This was somebody that delivered maybe about a week prior to that time, started having headaches at home, felt it was stress of taking care of the baby, you know, did not present to the hospital. I only presented when it got so bad and it was already very late. We have headaches, especially after delivery. Please check it out. It may be a sign of postpartum hypertension. postpartum preeclampsia, going on. And usually that type of preeclampsia is even more dangerous than the one that happens before delivery. Usually more dangerous than the one that happens before delivery. Now, offensive vaginal discharge might also mean that there's what we call puerperal sepsis. Puerperal sepsis. When I was mentioning the causes of maternal death earlier in the presentation, we talked about sepsis as one of the commonest causes of maternal mortality. So if you deliver and there's an offensive discharge, few days after delivery, it might be a sign that you're having puerperal sepsis. Sometimes it may be that, there's a retained product of conception, there's a retained membrane or placenta tissue that was not expelled at delivery, that is causing some infection. And in pregnancy or around pregnancy, those type of infections can spread very easily and cause pelvic sepsis or sometimes overwhelming sepsis, and it can be very dangerous. Can be very, very dangerous. And cause what we call gram-negative sepsis. Gram-negative sepsis sometimes does not respond, to regular antibiotics and may require, admission. In fact, gram-negative sepsis can require admission to ICU sometimes, to an intensive care unit, if that person will survive. Okay, so take offensive vaginal discharge very serious. When that happens, present to the hospital, it will be evaluated, the test will be done, a scan will be done to check, that there are no retained products, for instance. Bleeding also coming up here again, excessive bleeding this time around. Yes, when a woman delivers, she is expected to have some form of bleeding, but this type of bleeding is called a lochia. Lochia rubra. It's expected that the woman will have red bleeding, that's lochia rubra, in the first maybe 5 to 7 days after delivery, and it should not be much. It should not be much, and it should be reducing every day after delivery. Uh, in fact, in most cases, by the third day, fourth day after delivery, that redness should have changed to a pinkish discharge, indicating that the bleeding has subsided. And in standard cases, by 1 week after delivery, that bleeding should have been clear, should have turned to what we call lochia serosa. No, it should have been white or off-white at that stage. So if you have a situation, first 3 days, bleeding is much, should complain in the hospital. It might mean that maybe there's a genital tract laceration somewhere for those that have vaginal delivery, even a cesarean section. It might mean that there's a problem somewhere. It should not be heavy. It might mean that there are retained product of conception also, if bleeding is excessive. And it might also mean that there's an infection. Sometimes an infection will also cause excessive bleeding. Though a lot of times in the puerperal stage, in the first 6 weeks, people might have on and off bleeding, but it should not be heavy. Excessive bleeding, any more than normal, is a danger sign even after delivery. All right, so those are danger signs. I think I've been speaking for about 1 hour now. Don't think Well, components of B-pair, I will just quickly run through this just because it's part of my slide. B-pair means bad preparedness and emergency readiness, and is something that everybody should be aware of in preparation for delivery. Well, it starts with, planning your pregnancy, even though we know that 50 to 60% of pregnancies are not planned, but it's always good to plan, every pregnancy, every child coming to this world. It's good to plan for them because a lot is involved in pregnancy and taking care of a newborn, and it's not cheap either, So family planning is important. We just talked about recognizing signs of main complication of pregnancy. That's a component of bad preparedness and emergency readiness. Birth plan, so everybody should plan properly where they want to deliver, know your acuture, be sure where you are delivering, make proper inquiry about the place you are delivering at, to be sure you're in the right hands. Shop early by 30 weeks, 32 weeks maximum. I believe that everybody should have done their maternal shopping. Their delivery pack should be ready. You should know that those who's going to assist you when you come to deliver in labor, those that will stand with you. Usually we allow at least one person, to be with you in the labor ward. Somebody that understands childbirth, most especially, is the person that will usually prefer to be with you, not necessarily your partner. Your partner may not be the best person to stay with you. That's the truth. For some reasons. Arrangement for transportation. Arrangement for transportation is very important. We don't expect a woman in labor to be the one driving herself to the hospital. It's very dangerous, driving, having contraction and slamming brakes can be very dangerous. That would not be a maternal, God forbid, if you understand my definition of maternal death, you will know that the accidents are not included as maternal deaths. So don't drive when you're in labor. Make arrangements. Fund for expenses, very important. Make inquiries, what it costs for your antenatal package, what it costs for delivery, whether vaginal delivery or a cesarean section. I usually advise people to prepare for both. A vaginal delivery may end up in a cesarean section, in an emergency situation. So be prepared. Have funds for that ready. Care of children, good for those that have babies, that have young children. You should have made plans for where they will stay when you present to the hospital in labor. Plans for people that will stay with you, in late pregnancy, family, relatives, anybody. Then lastly, signs of labor. Signs of labor, all those in the third trimester should be aware of signs of labor, which is passage of show, painful regular contractions that happens every 10 minutes, and drainage of liquor, like I mentioned before. Okay, so that's BPAIR at a glance. So thank you very much. I will now give opportunity for questions, comments, on the presentation as we round up. Thank you very much.